Welcome to Nexus Clinical. Before diving into this lecture, I want to ensure we're all on the same page. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this content is at the user's risk. This is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay seeking medical advice for any medical condition they have, and they should consult their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.
Let's establish a foundation for understanding withdrawal syndromes. A crucial topic in medical education is essential for understanding complex concepts such as withdrawal syndrome. Withdrawal syndrome is a dysfunctional state that arises when an individual who has physiologically adapted to a substance experiences a decrease or removal of that substance. This adaptation persists even as the concentration of the substance declines. It is important to note that withdrawal syndrome requires both a pre-existing physiological adaptation to a substance and a decrease in its concentration. At its core, withdrawal involves a significant reduction in tonic inhibitory neurotransmission, resulting in a state of excitation within the central nervous system. Chronic exposure to a substance disrupts the balance between excitation and inhibition. This disruption triggers adaptive changes in neurons that necessitate the presence of a substance to maintain baseline activity. When the substance is removed, maladaptive changes occur, leading to various clinical symptoms. It is crucial to distinguish withdrawal from simple tolerance and addiction. Tolerance refers to a shift in the dose-response curve, requiring more of the substance to achieve the same effect. In contrast, addiction is characterized by compulsive drug-seeking behavior despite experiencing adverse consequences. Withdrawal syndromes often involve substances that affect inhibitory pathways. For instance, withdrawal syndromes can be related to substances targeting GABA A receptors such as barbiturates, benzodiazepines, ethanol, and volatile solvents. Other substances include those that act on GABA B receptors, such as baclofen and gamma-hydroxybutyrate GHB. Opioids target opioid receptors, while clonidine and dexmedetomidine interact with alpha-2 adrenergic receptors. Caffeine affects adenosine receptors, nicotine interacts with acetylcholine receptors, and selective serotonin reuptake inhibitors, commonly known as SSRIs, have their own specific effects. To gain a deeper understanding of withdrawal syndromes, we will explore the pathophysiology of each class of xenobiotic. This will include discussions of clinical presentations, diagnostic approaches that involve laboratory tests and imaging techniques, as well as management strategies tailored to each case. Understanding these concepts is fundamental in medical education, particularly in the fields of toxicology and emergency medicine. The objectives outlined here highlight the essential knowledge and skills that students should acquire from their studies. One of the key learning objectives is to define withdrawal syndrome. It is important to explain the general pathophysiology that underlies these syndromes. Students should also be able to describe the various neurobiological mechanisms that contribute to tolerance and dependence. Furthermore, they need to summarize the receptor targets and specific pathophysiological pathways involved in withdrawal syndromes that are associated with different classes of xenobiotics. In addition, students must identify and describe the characteristic clinical presentations of withdrawal syndromes across various classes of xenobiotics. They should also be able to formulate a systematic diagnostic approach for suspected withdrawal syndromes. It is crucial to discuss the role and limitations of primary laboratory tests and imaging studies in the evaluation of patients who present with suspected withdrawal syndromes. Moreover, students must apply the principles of pharmacological management for specific withdrawal syndromes. They should outline the management strategies for withdrawal syndromes related to other specific classes of xenobiotics as well. Finally, it is essential to recognize the importance of supportive care in these cases. Let's delve into the intricate pathophysiology of withdrawal syndromes. Understanding these mechanisms is fundamental in medical education because it informs our clinical approach to patients experiencing the effects of substance cessation. Withdrawal syndromes arise when an individual who has developed a physiological adaptation to the continuous presence of a foreign substance experiences a reduction or removal of that substance. This results in a dysfunctional state where the adaptive changes persist despite the decreasing concentration of the foreign substance. At its core, withdrawal is characterized by a significant reduction in tonic inhibitory neurotransmission, which leads to a state of excitation within the central nervous system. Under normal physiological conditions, the central nervous system maintains a delicate balance between excitatory and inhibitory neuronal activity. Excitatory neurons fire regularly while inhibitory neurons moderate the transmission of these impulses. Actions occur when this inhibitory tone diminishes, allowing excitatory impulses to reach their targets. Chronic exposure to certain foreign substances disrupts this balance. This disruption often occurs by enhancing inhibitory processes or inhibiting excitatory ones. The sustained presence of the foreign substance triggers adaptive changes in affected neurons, which require its continued presence to maintain baseline neuronal activity and prevent dysfunction. When the foreign substance is removed or reduced, these adaptive changes become maladaptive, which manifests as the clinical signs and symptoms of withdrawal. A withdrawal syndrome has two key characteristics. First, there is a pre-existing physiological adaptation to a foreign substance whose continuous presence prevents the withdrawal state. Second, there is a decrease in the concentration of that foreign substance. This dependence needs to be distinguished from simple tolerance, which is a physiological adaptation that shifts the dose-response curve to the right, requiring more of the substance for the same effect. It must also be distinguished from addiction, which is characterized by compulsive drug-seeking behavior despite adverse consequences. The unifying pathophysiologic pattern of withdrawal syndromes often involves xenobiotics that affect inhibitory neuronal pathways, such as those acting on GABA receptors, opioids, or alpha-2 adrenergic receptors. Xenobiotics that primarily affect excitatory pathways like cocaine are described as producing a post-intoxication syndrome rather than a true withdrawal syndrome by this definition, because the second criterion, taking the same or related substance to relieve symptoms, is not typically met. The symptoms of cocaine's post-intoxication syndrome, often called the crack crash or washed-out syndrome, are thought to be caused by the depletion of presynaptic neurotransmitter stores, particularly dopamine, after prolonged use, leading to diminished baseline adrenergic activity and symptoms like lethargy and depressed vital signs. This state is usually self-limiting and resolves spontaneously with supportive care. Research has identified several genomic and non-genomic effects that contribute to neuroadaptation and the development of withdrawal syndromes. These effects depend on the class of receptors primarily affected by the xenobiotic. The mechanisms involved in these processes can develop rapidly and modify the receptor and its function in complex ways. The first mechanism is related to genomic processes which involve alterations in gene expression. This includes changes in messenger RNA and peptide concentrations that lead to alterations in the composition or expression of receptor subunits. The second mechanism involves second messenger effects. These effects are mediated by protein kinases, cyclic adenosine monophosphate, or calcium ions. For instance, during opioid withdrawal, the activation of CAMP response element binding protein increases the expression of adenylyl cyclase, which leads to increased levels of cyclic adenosine monophosphate and subsequent downstream effects. In the case of nicotine withdrawal, there is a selective upregulation of the CAMP pathway that has been implicated. Additionally, chronic caffeine administration is associated with increases in G protein-stimulated adenylyl cyclase. Another mechanism is receptor endocytosis, which refers to the removal of receptors from the cell surface. This process is a form of desensitization and downregulation that is observed with chronic opioid use and contributes to the development of tolerance. The expression of various receptor subtypes represents another important mechanism. Depending on their synaptic localization, different receptor subtypes may be expressed or their subunit composition may be altered. For example, chronic alcoholism can cause a shift in GABA A receptor subunits characterized by the underexpression of the alpha-1 subunit and the overexpression of the alpha-4 and gamma-1 subunits. Intracellular signaling is also a significant mechanism whereby effects are mediated through interactions with other receptors or intracellular pathways. For example, N-methyl diaspartate receptors are involved in intracellular signaling, which helps to explain the kindling hypothesis observed during alcohol withdrawal. Opioid receptor activity influences effects via G proteins, which alter cell conductance and various signaling pathways. Finally, neurosteroid modulation affects GABA receptor sensitivity and expression. This modulation is mediated by neurosteroids and illustrates yet another layer of complexity in the mechanisms contributing to neuroadaptation and withdrawal syndromes. Let's look at the pathophysiology for specific classes of xenobiotics. GABA A receptors are ligand-gated ion channels that facilitate an inward chloride current when activated by gamma-aminobutyric acid, commonly known as GABA. This activation hyperpolarizes the neuron, subsequently decreasing its likelihood of firing. Benzodiazepines serve to increase the frequency at which chloride channels open, while barbiturates prolong the duration of these openings. Both classes of substances enhance the inhibitory effect of GABA. Additionally, ethanol enhances GABA, a receptor-mediated neurotransmission, although it remains unclear whether ethanol acts as a direct agonist or as a potentiator. Volatile solvents such as gasoline, diethyl ether, and toluene also appear to mediate their central nervous system inhibitory and anesthetic effects through the GABA A receptor, akin to the effect seen with ethanol. Chronic exposure to substances that enhance GABA A receptor activity, such as ethanol, induces adaptive changes within the body. One significant adaptation is the downregulation and desensitization of the GABA A receptor complex. This process involves alterations in receptor gene expression, which occurs through changes in messenger RNA and peptide concentrations. It also includes modifications to the subunit composition, such as a shift from alpha-1 to alpha-4 and gamma-1 subunits, as well as functional changes. These adaptations can manifest rapidly, often occurring within an hour following the administration of a single dose of ethanol. At the same time, chronic ethanol use inhibits the functionality of the excitatory N-methyl diaspartate subtype of glutamate receptors. This inhibition triggers a compensatory upregulation of these receptors to maintain balance within the nervous system. When ethanol or another gamma-aminobutyric acid type A agonist is withdrawn, the constant inhibitory stimulation is removed. This withdrawal leads to a combined effect of reduced gamma-aminobutyric acid type A receptor activity due to downregulation and increased N-methyl diaspartate receptor activity due to upregulation. Consequently, there is a significant reduction in tonic inhibitory neurotransmission alongside an increase in glutamatergic activity. This loss of inhibitory control over excitatory neurotransmission is mediated by the upregulated N-methyl diaspartate receptors and manifests clinically as central nervous system excitation. Symptoms may include tremors, hallucinations, and seizures, along with autonomic stimulation, such as tachycardia, hypertension, hyperthermia, and diaphoresis. Repeated episodes of ethanol withdrawal may result in permanent alterations in neurotransmitters and their receptors. This leads to persistent and progressive electroencephalographic abnormalities. The underlying neurobiological plasticity contributes to what is known as the kindling phenomenon, in which successive withdrawal events become increasingly severe and potentially more resistant to treatment. This is due to the heightened activity of excitatory neurotransmission with repeated firing a process known as long-term potentiation. The resulting upregulation of N-methyl diaspartate receptors, paired with diminishing gamma-aminobutyric acid type A receptor activity, contributes to the escalating severity of symptoms associated with withdrawal. Let's delve into the clinical presentation of withdrawal syndrome stemming from substances that primarily target the GABA-A receptor. Understanding the neurobiological underpinnings is key to appreciating the diverse clinical manifestations observed. Withdrawal is fundamentally a dysfunctional condition resulting from the brain's adaptation to the chronic presence of a foreign substance, which then persists when the substance is removed or significantly reduced. In essence, substances acting on the GABA-A receptor enhance inhibitory neurotransmission. Chronic exposure triggers adaptive changes in the affected neurons, creating a state where the continuous presence of a substance is required to maintain normal function. When this substance is withdrawn, the adaptive changes remain, leading to a significant reduction in tonic inhibitory neurotransmission and a state of excitation. The core pathophysiology involves a shift in the delicate balance between excitatory and inhibitory neurotransmission in the central nervous system. Under normal conditions, actions in neurophysiology often result from a reduction in inhibitory tone, allowing excitatory impulses to travel. GABA-A receptors are ligand-gated ion channels that mediate inhibition by facilitating an inward chloride current. This action hyperpolarizes the neuron and decreases its likelihood of firing and action potential. Substances like barbiturates and benzodiazepines bind to specific sites on the GABA-A receptor complex, enhancing GABA's inhibitory effects. Ethanol also interacts with GABA-A receptors, potentially enhancing their function. Chronic use of these agents, particularly ethanol, leads to adaptive changes that include the downregulation of GABA-A receptor complexes and alterations in their subunit composition. For example, there may be underexpression of alpha-1 subunits and overexpression of alpha-4 and gamma-1 subunits. Concurrently, excitatory systems, such as those mediated by the N-methyl diaspartate subtype of glutamate receptors, may undergo compensatory upregulation. When the GABA-A agonist is withdrawn, the loss of its inhibitory effect, combined with the persistent adaptive changes including upregulated excitatory pathways, leads to a state of neuronal hyperexcitability. This heightened excitation is the root cause of the clinical signs and symptoms observed in withdrawal syndromes associated with GABA-A agonists. The phenomenon of concomitant increased excitation and loss of inhibition manifests clinically as autonomic excitability and psychomotor agitation. Repeated withdrawal episodes can exacerbate this process, potentially leading to permanent alterations in neurotransmitters and receptors. This contributes to the kindling phenomena, where subsequent withdrawal events become progressively more severe and potentially more resistant to treatment. The clinical presentation of GABA-A receptor withdrawal is characterized by central nervous system excitation and autonomic stimulation. While the specific manifestations can vary depending on the substance, dose, duration of use, and individual patient factors, a common spectrum of symptoms is observed, particularly with alcohol and traditional sedative hypnotics like benzodiazepines and barbiturates. Centrally, excitation often begins with tremor. This is frequently one of the initial and most common symptoms, typically starting as a fine tremor that can progress to a coarse tremor in more severe withdrawal. This represents hyperactive muscular activity stemming from central nervous system hyperexcitability. Agitation is also common, and patients often exhibit psychomotor agitation that can range from mild irritability to extreme agitation. This reflects the underlying noradrenergic hyperactivity in the locus coeruleus and general central nervous system excitation. An altered mental status can be evident, with variations ranging from anxiety and emotional lability in milder cases to confusion, delirium, and frank psychosis in more severe manifestations. Delirium is a key feature of delirium tremens, the most severe form of alcohol withdrawal, and altered sensorium is distinctive in this condition. Hallucinations may occur, including perceptual disturbances such as visual, tactile and auditory hallucinations. In alcoholic hallucinosis, patients may experience hallucinations, typically visual or auditory, and sometimes of a persecutory nature, with otherwise clear mentation. This can take place independently of other withdrawal signs. Seizures are a serious manifestation, particularly generalized tonic-clonic seizures. With alcohol withdrawal, these seizures typically occur within 6 to 48 hours of cessation and are usually brief. Often referred to as rum fits, they can even be the first manifestation of withdrawal. Status epilepticus is less common, occurring in less than 3% of cases. Seizures are also a common sign of benzodiazepine withdrawal. It is notable that although seizures are listed as a potential manifestation of gamma-hydroxybutyric acid withdrawal, they do not appear to be a common manifestation in humans, with myoclonus seen more frequently. Other symptoms associated with central nervous system disturbances include insomnia, irritability, dysphoria, and paranoia. Additionally, headaches are commonly reported. In terms of autonomic stimulation and hyperactivity, tachycardia, or increased heart rate is a common finding. Elevated blood pressure or hypertension is frequently observed alongside excessive sweating, referred to as diaphoresis. Hyperthermia, or increased body temperature, can occur, particularly in severe withdrawal such as in delirium tremens. This can worsen due to hyperactive muscular activity. Other autonomic symptoms that may arise include miosis or pupil constriction, noted in the context of autonomic instability during delirium tremens. Gastrointestinal symptoms such as anorexia, nausea, and vomiting are also commonly reported. The specific timing and trajectory of these symptoms can differ based on the half-life and metabolic profile of the substance. For example, alcohol withdrawal can begin as early as 6 hours after cessation, with early symptoms presenting within hours to several days. Withdrawal from gamma-hydroxybutyric acid and gamma-butyrolactone generally occurs within 1 to 6 hours following the last use. Withdrawal from benzodiazepines with active metabolites, such as diazepam, may not manifest symptoms for up to a week after cessation. The spectrum of alcohol withdrawal syndrome provides a useful framework for understanding the progression of symptoms. Mild alcohol withdrawal syndrome is characterized by autonomic hyperactivity, including tachycardia, tremor, hypertension, and diaphoresis alongside psychomotor agitation, which can manifest as anxiety, emotional lability, insomnia, irritability, anorexia, and headaches. Moderate alcohol withdrawal syndrome consists of exacerbated mild symptoms, along with increased agitation and coarser tremor. Severe alcohol withdrawal syndrome, or delirium tremens, encompasses increasingly severe moderate symptoms progressing to confusion, delirium, hallucinations, and potentially tonic-clonic seizures. Autonomic instability is pronounced, leading to hyperthermia, severe tachycardia, hypertension, and diaphoresis. Delirium tremens represents the most severe and potentially life-threatening manifestation of alcohol withdrawal. Sedative hypnotic withdrawal, benzodiazepines, barbiturates may be clinically indistinguishable from alcohol withdrawal, although seizures are noted as a common sign of benzodiazepine withdrawal. GHB withdrawal is described as similar to ethanol and benzodiazepine withdrawal and can be severe and potentially life-threatening. Its manifestations include tachycardia, hypertension, tremors, agitation, dysphoria, nausea, vomiting, auditory and visual hallucinations, and seizures. However, as noted earlier, human data on GHB withdrawal seizures are less clear, with myoclonus potentially being mistaken for seizures. It is crucial to distinguish withdrawal syndromes from other conditions that may mimic similar symptoms, such as sympathomimetic toxicity, e.g. from amphetamines, cocaine, cathinones, caffeine, theophylline, anticholinergic toxicity, or various medical conditions like thyroid storm, hypoglycemia, encephalitis, meningitis, or even neuroleptic malignant syndrome or serotonin toxicity. Diagnostic testing may be necessary to rule out these differential diagnoses and to assess for common comorbidities or complications in patients with substance dependence, such as metabolic derangements, infections, or liver dysfunction. In summary, withdrawal from substances acting on GABA A receptors results from neuroadaptation, leading to decreased inhibition and increased excitation upon xenobiotic removal. The clinical presentation reflects this hyperexcitability, manifesting as a spectrum of CNS excitation, tremor, agitation, altered mental status, hallucinations, seizures, and autonomic stimulation, tachycardia, hypertension, diaphoresis, hyperthermia. Recognizing these characteristic signs and symptoms, understanding the underlying pathophysiology, and considering the specific substances' pharmacokinetics are essential for appropriate diagnosis and management. The clinical presentation, diagnostic approach, and necessary investigations for withdrawal syndromes associated with substances that primarily interact with the GABA-A receptor are critical topics in medical toxicology and emergency medicine. This is because withdrawals can range in severity from uncomfortable to life-threatening. The diagnosis of withdrawal from GABA-A receptor-related substances is primarily clinical and relies on the characteristic constellation of signs and symptoms that manifest after the cessation or significant reduction in usage. This is particularly pertinent in patients with a history of dependence. According to the Diagnostic and Statistical Manual of Mental Disorders, 5th edition, alcohol withdrawal is defined as occurring after the cessation of heavy or prolonged use within hours to days, leading to the presence of 2 or more specific clinical findings. Key components of the diagnostic process involve thorough history taking and physical examination. It is essential to use scoring systems and consider the differential diagnosis. Eliciting a history of heavy or prolonged use of substances such as alcohol, benzodiazepines, barbiturates, volatile solvents, or gamma-hydroxybutyric acid is crucial. Inquiries about the timing of the last dose and previous withdrawal episodes can provide insights into predicting the severity of the condition, a phenomenon known as kindling. However, it is essential to note that patients may not always willingly share this information. They may also present with symptoms that led them to discontinue usage, which may include an underlying illness. A comprehensive physical examination is necessary to assess for the classic signs of central nervous system excitation. Symptoms that should be carefully observed include tremor, agitation, altered mental status, evidence of hallucinations, and seizure activity. Furthermore, signs of autonomic hyperactivity, which may include tachycardia, hypertension, excessive sweating, and fever, are also paramount in the diagnostic process. Symptom-triggered therapy for alcohol withdrawal often employs validated scoring systems. The Clinical Institute Withdrawal Assessment for Alcohol Scale, Revised, and the Richmond Agitation Sedation Scale are examples of assessment tools that aim to standardize evaluation and guide medication dosing. However, it is important to recognize the limitations of these scales. These limitations may encompass subjectivity in patient-reported symptoms, variability between assessors, and the risk of misuse if these tools are not utilized as monitoring instruments after initial symptom control has been achieved. Considering the differential diagnosis is another critical step in accurately diagnosing withdrawal. It is vital to exclude other conditions that may present with similar symptoms, such as agitation, altered mental status, autonomic instability, seizures, and hyperthermia. Potential mimicking conditions to consider include sympathomimetic toxicity caused by substances such as cocaine, amphetamines, cathinones, caffeine, or theophylline. Other important considerations involve anticholinergic toxicity, neuroleptic malignant syndrome, serotonin toxicity, thyroid storm hypoglycemia, encephalitis, meningitis, or head trauma. It is not uncommon for patients in withdrawal to have underlying medical conditions that triggered their abstinence. These conditions, which may include pancreatitis, pneumonia, gastrointestinal hemorrhage, or head trauma, must all be identified during the diagnostic process. Laboratory and imaging studies in the context of suspected withdrawal from GABA-A receptor substances are primarily utilized to assess for comorbidities, evaluate nutritional status, rule out differential diagnoses, and identify complications. However, it is important to note that these studies do not definitively diagnose withdrawal itself. Primary laboratory tests play a crucial role in assessing patients with alcohol dependence. Standard chemistries should be examined, which include glucose, magnesium, and calcium levels. Many patients with alcohol dependence often experience poor nutritional status, leading to metabolic derangements that can arise from vomiting and diarrhea. For instance, hypomagnesemia is identified as a non-toxic differential diagnosis that can mimic withdrawal symptoms. Abnormalities in serum chloride and potassium levels have also been linked to the development of alcohol withdrawal syndrome (AWS). However, assessing their predictive value for severity is challenging due to low specificity. Furthermore, elevated homocysteine levels have been noted during alcohol withdrawal, indicating additional biochemical disturbances. The complete blood count, CBC, is another essential test that assesses various cell lines, as bone marrow suppression and hidden hemorrhage are frequent in individuals with alcoholism. An elevated white blood cell count may suggest an infection, but it can also reflect a stress response in these patients. Liver function tests and coagulation assays are particularly important for alcoholic patients, as they help evaluate hepatic synthetic function. It should be noted that, paradoxically, severe alcohol withdrawal demonstrates a negative association with histopathologic cirrhosis. This complicates the utilization of routine liver tests for making predictions regarding withdrawal severity. Serum ethanol concentration serves as a potentially helpful prognostic tool. Patients undergoing withdrawal who present with elevated ethanol concentrations may experience more severe withdrawal symptoms. However, conflicting study results regarding its predictive value for severity or the necessity for treatment highlight the importance of interpreting this concentration within the context of clinical presentation and patient tolerance. Specific substance testing is necessary for substances such as gamma-hydroxybutyrate (GHB) and gamma-butyrolactone (GBL). Routine drug abuse screening typically excludes GHB. Thus, specialized testing for GHB and its analogs such as GBL1 for butanediol-1 for BD can be conducted via gas chromatography mass spectrometry on urine and serum samples, especially if drug-facilitated sexual assault is suspected or for forensic investigations. Interpretation of these results demands consideration of the cutoff concentrations needed to distinguish endogenous production from exogenous consumption, because GHB, GBL, and 1 for BD occur naturally in the body. Notably, due to rapid metabolism, concentrations may return to baseline quickly in patients naive to the drug as they recover. Other routine laboratory tests typically yield normal results in cases of GHB toxicity. Imaging studies are essential in patients presenting with altered mental status or seizures to rule out structural causes or other medical conditions. A computed tomography (CT) scan of the head is critical in the evaluation of a patient in withdrawal who displays altered consciousness or seizures. A head CT can illuminate conditions that may be misdiagnosed as delirium, such as subdural hematomas, cerebral edema, or other intracranial conditions. Moreover, it should be included in the assessment of any individual with new-onset seizures before alcohol withdrawal seizure is definitively diagnosed. A chest radiograph is also important to help exclude pneumonia, a common comorbidity in patients with alcohol dependence that can lead to symptoms mimicking withdrawal. An abdominal CT scan can be useful in identifying other conditions in the differential diagnoses that may have resulted in abstinence and the subsequent withdrawal, such as pancreatitis, cholecystitis, or intestinal obstruction. To summarize, diagnosing GABA, a receptor withdrawal, mainly relies on clinical evaluations based on the typical presentation of central nervous system excitation and autonomic stimulation in patients with a history of dependence who have recently ceased or reduced their alcohol intake. Laboratory tests are employed to assess comorbidities, metabolic issues, and nutritional status, while imaging studies are vital to eliminate the possibility of structural central nervous system pathologies and other medical conditions that could mimic withdrawal symptoms. Recognizing the clinical spectrum, ranging from mild agitation to severe delirium and seizures, is essential for timely and effective management. Managing withdrawal syndromes that arise from substances impacting the central nervous system inhibitory neurotransmitter system, particularly the gamma-aminobutyric acid type A receptor, is essential in patient care. This discussion will explore the principles and management techniques for withdrawal from these agents based on the relevant literature. The management of a withdrawal syndrome typically involves the readministration of the substance that the patient is withdrawing from. A crucial concept in treating withdrawal syndromes is cross-tolerance. This occurs when two different drugs share sufficient common receptor or metabolic activity, allowing one drug to be substituted for another to prevent or alleviate withdrawal symptoms. This principle is especially important in the treatment of substances such as ethanol, benzodiazepines, barbiturates, baclofen, and gamma-hydroxybutyric acid or gamma-butyrolactone. A systematic approach to manage withdrawal syndromes, according to the class of receptors primarily affected, can significantly enhance patient care. While withdrawal from substances like opioids, alpha-2 adrenergic agonists, adenosine, acetylcholine, and serotonin reuptake inhibitors involves different receptor systems and requires various management strategies, evidence, and expert opinion focus on withdrawal syndromes related to gamma-aminobutyric acid type A receptors. The management of these syndromes often overlaps due to clinical similarities and cross-tolerance. Specifically, the withdrawal from ethanol, sedative hypnotic substances such as barbiturates and benzodiazepines, and gamma-hydroxybutyric acid or gamma-butyrolactone warrant particular attention due to their related withdrawal challenges. Ethanol withdrawal is a common and often severe syndrome that represents a complex spectrum of psychomotor agitation and increased sympathetic tone. It can range from mild, early symptoms such as tremor, tachycardia, hypertension, diaphoresis, and anxiety, which appear within hours of cessation, to more severe presentations that include perceptual disturbances, true autonomic instability, and seizures. Benzodiazepines are the first-line agents for managing alcohol withdrawal. They are cross-tolerant with ethanol and act on GABA-A receptors to restore inhibitory tone. Additionally, they are excellent anticonvulsants. The goal of therapy is to gain control of withdrawal symptoms early. For mild to moderate withdrawal, low-dose oral benzodiazepines are typically used. While fixed-schedule regimens are common, studies suggest that front-loading with doses such as 10 to 20 milligrams of oral diazepam at 1 to 2-hour intervals until the patient is asymptomatic can relieve symptoms faster. This approach may also reduce the total amount of medication needed. Similarly, as-needed chlordiazepoxide has been shown to require less total drug and reduce treatment time compared to fixed-schedule dosing. Moderate to severe withdrawal is potentially life-threatening and often requires parenteral administration of sedatives or anesthetics. This situation may sometimes necessitate endotracheal intubation. While most patients respond to conventional doses of benzodiazepines, some may require larger amounts. If a patient does not respond adequately to large initial doses of benzodiazepines, such as more than 200 milligrams of diazepam equivalent, alternative agents should be considered. Historically, barbiturates have served as the second-line treatment for individuals experiencing severe alcohol withdrawal. An example of this is phenobarbital, which remains effective even when the alpha subunits of the GABA-A receptor are downregulated in chronic alcoholics. This effectiveness is due to phenobarbital's ability to act directly on the ion channel, independent of the normal expression of subunits. A recent study indicated that administering a single dose of phenobarbital alongside standard lorazepam treatment significantly decreased the need for intensive care unit admissions related to alcohol withdrawal without increasing the occurrence of adverse events. However, phenobarbital does have a lag time before it takes effect, which can complicate its titration, and short-acting barbiturates may result in prolonged sedation. Therefore, optimal treatment with either benzodiazepines or barbiturates aims to keep the patient sedated yet arousable. Following treatment, gradual tapering is essential, which may be aided by using agents with longer half-lives or active metabolites such as diazepam or chlordiazepoxide. In recent years, propofol has gained popularity, particularly in intensive care settings, as a treatment for refractory alcohol withdrawal. This is supported by Grade 2-3 evidence. Propofol offers a rapid onset and offset of sedation, has anticonvulsant properties, and much like alcohol, acts as both a GABA agonist and an NMDA antagonist. These qualities may account for its effectiveness in cases where benzodiazepines fail. Despite these advantages, propofol's high cost and narrow therapeutic index necessitate careful monitoring for respiratory depression. While it is beneficial for intubated patients, benzodiazepines continue to be the primary treatment option. Furthermore, ketamine and dexmedetomidine have been investigated as adjunctive treatments when combined with benzodiazepines for alcohol withdrawal. However, Grade 3 evidence indicates that more research is required before formal recommendations can be established for these agents. Certain agents should be avoided when used as monotherapy. Antipsychotics, beta blockers, and clonidine may assist in managing symptoms such as psychosis and autonomic instability, but they fail to address the underlying neurochemical imbalance present in the central nervous system. Therefore, they are not recommended as sole treatments. These medications can obscure symptoms, leading to inadequate care. Neuroleptics, particularly haloperidol, pose additional concerns as they are not cross-tolerant with sedative hypnotics. They can decrease the seizure threshold, exacerbate tachycardia, impair the body's ability to dissipate heat, and studies and case reports have shown that they can worsen sedative hypnotic withdrawal. Similarly, methods that rely on non-sedative hypnotics often focus on peripheral effects rather than addressing the central mechanisms at play. Seizures can occur during any stage of alcohol withdrawal and are typically self-limited. Benzodiazepines are the preferred treatment for these seizures, with lorazepam demonstrating efficacy in reducing the risk of recurrent seizures and the need for hospital admissions. Phenytoin, however, is ineffective for preventing recurrent seizures associated with alcohol withdrawal, as it does not modulate the primary mediators involved, specifically the GABA or NMDA receptors. It is indicated only for seizures that arise from non-alcohol-related causes or underlying seizure disorders. Finally, achieving control of withdrawal symptoms at an early stage is of utmost importance. One practical definition utilized in various clinical settings is attaining a Richmond agitation-sedation score of -1, which indicates that the patient has closed their eyes, appears to be resting comfortably, and wakes to voice, remaining free from the need for additional medications for a duration of 1 hour. Withdrawal from sedative hypnotics, such as benzodiazepines and barbiturates, can appear clinically similar to alcohol withdrawal. However, the timing of onset may vary depending on the half-life of the drug and its active metabolites. Seizures are a frequently observed symptom during benzodiazepine withdrawal. The approach to pharmacological management is informed by the principle of cross-tolerance and the shared mechanism involving the GABA-A receptor. Benzodiazepine withdrawal typically responds well to treatment with benzodiazepines, supported by Grade 2 evidence. In a similar vein, barbiturate withdrawal would logically respond favorably to the readministration of a barbiturate. The treatment strategies for both types of withdrawal leverage the same foundational principles as those for alcohol withdrawal. The concept of cross-tolerance plays a central role in the management of withdrawal that relates to GABA-A activity. The effectiveness of benzodiazepines and barbiturates in treating withdrawal from ethanol directly arises from their common mechanism of enhancing GABA-A receptor activity. Although gamma-hydroxybutyric acid primarily targets GABA-B receptors, the clinical similarities of its withdrawal syndrome, along with the recognized efficacy of benzodiazepines, barbiturates, and propofol in its management, underscore the clinical cross-reactivity. This similarity supports a parallel approach to treatment that is guided by the resultant excitatory state. Baclofen, which is a GABA-B agonist, is also employed for the management of gamma-hydroxybutyric acid withdrawal, addressing the primary receptor involved. Additionally, benzodiazepines or GABA-A agonists may be utilized to control seizures associated with baclofen withdrawal. In summary, managing withdrawal syndromes stemming from GABA-A agonists and clinically similar conditions requires a thorough understanding of the underlying shift towards central nervous system excitation. Benzodiazepines serve as the primary therapeutic agents due to their cross-tolerance and their capacity to enhance GABA-A-mediated inhibition. In cases that do not respond adequately, barbiturates and propofol are crucial alternatives, utilizing either their direct effects on channels or a combination of mechanisms. Furthermore, supportive care diligent monitoring for potential complications, and prompt intervention to alleviate symptoms are essential components of efficient management. Baclofen is a GABA-B agonist that influences both presynaptic and postsynaptic inhibitory properties. Similar to GABA-A agonists, chronic use of baclofen can lead to dependence. Withdrawal symptoms are believed to stem from the cessation of the long-term inhibitory effect that baclofen has on postsynaptic GABA-B receptors. When baclofen is discontinued, there is a hyperactivity of neuronal calcium channels, specifically the N and P/Q type. This condition can result in serious consequences such as seizures, hypertension, hallucinations, psychosis, and even coma. Withdrawal from baclofen typically begins 24 to 48 hours after discontinuation or a reduction in dosage. Gamma-hydroxybutyrate, commonly known as GHB, is a unique substance found in nature, serving as an endogenous neurotransmitter. Individuals who consume large amounts of GHB or its analogs on a daily basis can develop tolerance and dependence. If these individuals abruptly stop or decrease their dosage, withdrawal symptoms may occur. GHB operates primarily through the GABA-B receptor, although there is also evidence suggesting the presence of a G protein-mediated GHB receptor. The withdrawal from GHB shares similarities with withdrawal from ethanol and benzodiazepines. The onset of GHB withdrawal is usually rapid, occurring within 1 to 6 hours after the last use, attributed to its swift metabolism. Symptoms of GHB withdrawal can include tachycardia, hypertension, tremors, agitation, dysphoria, nausea, vomiting, as well as auditory and visual hallucinations and seizures. The clinical manifestations of baclofen withdrawal are noteworthy and potentially severe. Withdrawal symptoms typically develop between 24 to 48 hours after either the discontinuation or a reduction in the dose of baclofen. Various case reports highlight a constellation of specific symptoms associated with this type of withdrawal. Key clinical findings include a range of significant concerns. Seizures are particularly notable because baclofen's inhibitory properties can paradoxically lead to seizures during withdrawal. Auditory and visual hallucinations are also reported, which may indicate a serious issue. Furthermore, psychosis can be a prominent feature of withdrawal from baclofen. Movement disorders, known as dyskinesias, can also manifest during this period. In addition, visual disturbances may occur, accompanied by symptoms such as hypertension and coma. The hyperactivity of neuronal calcium channels upon withdrawal has been linked to these severe manifestations. Symptoms of baclofen withdrawal may not differ clinically from the withdrawal symptoms observed with gamma-aminobutyric acid A receptor agonists, such as benzodiazepines. Evidence and expert opinions suggest that severe withdrawal can occur specifically when an intrathecal baclofen pump malfunctions or disconnects, in addition to withdrawal from oral doses due to reduction or discontinuation. While mild and brief autonomic instability, along with persistent psychotic symptoms, have been described in the context of gamma-hydroxybutyrate withdrawal, which is related as a GABA-B agonist, the symptoms specifically attributed to baclofen withdrawal, as noted in evidence and expert discussions, are those mentioned above. Diagnosing baclofen withdrawal primarily depends on the timing between the reduction or cessation of baclofen use and the appearance of characteristic clinical features. The withdrawal syndrome typically develops within a few hours to several days after heavy or prolonged substance use has ended. For baclofen specifically, this time frame usually falls between 24 to 48 hours after discontinuation or dose reduction. It is crucial to recognize the exposure history and the onset of symptoms such as seizures, hallucinations, psychosis, dyskinesias, visual disturbances, hypertension, or coma in patients receiving baclofen, as these are essential for accurate diagnosis. Additionally, similar to other withdrawal syndromes, the diagnosis should be established while excluding other potential medical, psychiatric, or toxicological disorders that could present with comparable symptoms. There are currently no specific laboratory tests or imaging studies that definitively diagnose baclofen withdrawal. However, When a patient presents with severe symptoms consistent with withdrawal, such as altered mental status, seizures, or notable autonomic instability, a comprehensive evaluation is necessary. This evaluation aims to rule out other life-threatening conditions and assess for complications, following a similar approach to the management of alcohol or sedative hypnotic withdrawal. Based on established principles for managing severe withdrawal syndromes, routine blood work may be essential for assessing underlying metabolic imbalances or complications. Evaluations might include measuring serum electrolytes such as glucose, magnesium, and potassium, as these imbalances can occur or imitate withdrawal symptoms. A complete blood count and liver function tests may also be pertinent, particularly if there are concerns regarding nutritional deficiencies or underlying organ damage often seen in chronic alcohol users. While inconsistent abnormalities can be observed in alcohol withdrawal syndrome laboratory tests, they may provide insights into comorbidities. For patients presenting with altered consciousness or seizures, imaging becomes a vital component of the diagnostic workup in order to exclude other causes. A computed tomography scan of the head is essential for ruling out intracranial pathology such as trauma, subdural hematoma, cerebral edema, or other structural lesions. A chest radiograph may be necessary to exclude pneumonia, a common comorbidity in patients with substance use disorders that can complicate their presentation. Although these studies do not specifically diagnose baclofen withdrawal, they are crucial for evaluating the patient's overall condition, identifying comorbidities, and excluding differential diagnoses that may present similarly. The management of baclofen withdrawal focuses on restoring the inhibitory tone that is lost when the drug is ceased. A key principle in treating withdrawal syndromes is the readministration of the xenobiotic from which the patient is withdrawing or a cross-tolerant agent. Specific management strategies for baclofen withdrawal involve reinstating baclofen. Returning to the previous baclofen dosing schedule appears to resolve the withdrawal symptoms within 24 to 48 hours. This approach directly addresses the underlying mechanism by restoring the gamma-aminobutyric acid B agonist effect. Pharmacological management is essential. For seizures induced by baclofen withdrawal, benzodiazepines and gamma-aminobutyric acid A agonists are considered appropriate treatments, while phenytoin is not suitable. This aligns with the general use of benzodiazepines as effective anticonvulsants in other withdrawal seizures, such as those from alcohol. Strategies that are effective in gamma-hydroxybutyric acid or sedative hypnotic withdrawal may also apply to baclofen withdrawal. Since baclofen acts as a gamma-aminobutyric acid B agonist like gamma-hydroxybutyric acid, the treatment protocols used for gamma-hydroxybutyric acid withdrawal, which are similar to those for alcoholic or sedative hypnotic withdrawal, may be beneficial. This is particularly relevant in severe or refractory cases where benzodiazepines, potentially in large doses, serve as mainstays of therapy for acute withdrawal symptoms. If symptoms do not respond to benzodiazepines, other sedative hypnotics such as barbiturates and propofol may be considered. Barbiturates are effective because they act directly on the chloride channel independent of specific gamma-aminobutyric acid A receptor subunits, which allows them to work even if receptor adaptations have taken place. Propofol is also a gamma-aminobutyric acid agonist and has been successfully used for refractory sedative hypnotic withdrawal due to its rapid onset and anticonvulsant properties. Interestingly, baclofen itself is considered a reasonable option in severe gamma-hydroxybutyric acid withdrawal because it targets the same gamma-aminobutyric acid B receptor. This further supports the idea of employing gamma-aminobutyric acid agents to manage the excitatory state of withdrawal related to this pathway. Supportive care is of utmost importance when dealing with severe withdrawal syndromes. It involves immediate assessment of the patient's airway, breathing, and circulation. Patients exhibiting profound symptoms may require endotracheal intubation to protect the airway. An evaluation for other medical or traumatic illnesses that may contribute to or complicate the presentation is critical. Fluid management for hypotension and temperature regulation in the event of hyperthermia is also necessary, as adequate volume replacement is essential. In addition, it is vital to prevent hospital-acquired complications such as elevating the head of the bed to avoid aspiration and providing prophylaxis against deep vein thrombosis if the patient is unable to move. Other agents, such as adrenergic antagonists like beta blockers or clonidine, and certain anticonvulsants such as carbamazepine or oxcarbazepine, are generally not recommended as monotherapy for severe withdrawal syndromes. This is because they do not address the central pathophysiological mechanisms and may mask symptoms. Therefore, benzodiazepines and other gamma-aminobutyric acid agents remain the cornerstone of pharmacological management for the core symptoms of baclofen withdrawal, particularly seizures and agitation. In summary, baclofen withdrawal is a potentially life-threatening condition caused by the loss of chronic gamma-aminobutyric acid B agonist effects. Its presentation includes significant neurological symptoms such as seizures, hallucinations, psychosis, and movement disorders. Diagnosis relies primarily on clinical assessment and patient history, whereas laboratory and imaging studies are utilized to rule out other conditions. The management of baclofen withdrawal necessitates the prompt reinstatement of baclofen or the use of benzodiazepines and other gamma-aminobutyric acid agents, accompanied by comprehensive supportive care. Gamma-hydroxybutyrate, gamma-butyrolactone, and 1,4-butanediol can lead to severe and potentially life-threatening withdrawal syndromes in individuals who use them daily in large quantities. While gamma-hydroxybutyrate primarily acts on the GABA-B receptor at supraphysiologic concentrations, its withdrawal syndrome is managed in a manner similar to that of ethanol and benzodiazepine withdrawal. The onset of withdrawal symptoms typically occurs 1 to 6 hours after the last dose. Clinical manifestations of withdrawal include an increased heart rate, elevated blood pressure, tremors, agitation, feelings of unease, nausea, vomiting, auditory and visual hallucinations, as well as seizures. Some distinctive clinical features of gamma-hydroxybutyrate withdrawal may include relatively mild and brief autonomic instability, but persistent psychotic symptoms. Additionally, dyskinesias and visual disturbances have been reported. The duration of withdrawal can be protracted, lasting between 3 to 5 days. The mainstays of therapy for acute gamma-hydroxybutyrate withdrawal symptoms are benzodiazepines and supportive care. It is not uncommon for patients to require large doses of benzodiazepines to control their symptoms. If the symptoms are refractory to benzodiazepines, other options such as barbiturates and propofol can be considered. Baclofen, which is a GABA-B receptor agonist, is also a reasonable consideration in severe gamma-hydroxybutyrate withdrawal. However, optimal dosing requires further research. In severe and refractory cases, endotracheal intubation may be necessary. The principles of treatment for this condition are similar to those for sedative hypnotic and alcohol withdrawal, focusing on restoring autonomic stability and reducing psychomotor agitation to achieve mild to moderate sedation. Opioids bind to various subtypes of opioid receptors, namely mu, kappa, and delta. This binding results in both genomic and non-genomic neuroadaptations that significantly involve second messenger effects. Opioid receptors are associated with GI/O proteins and function through adenyl cyclase. When opioids bind to these receptors, they alleviate pain by inhibiting neurons. This process activates GS proteins and stimulates potassium ion efflux currents, leading to the hyperpolarization of the cell and subsequent inhibition of its activation. As a result of decreased adenylyl cyclase activity, the levels of cyclic adenosine monophosphate are reduced. This reduction in cyclic adenosine monophosphate prevents the activation of protein kinase that mediates calcium ion influx. Collectively, these effects lead to central nervous system depression and analgesia. Chronic use of opioids leads to various cellular and synaptic adaptations. These adaptations include desensitization and the internalization or downregulation of opioid receptors, which contribute to the development of tolerance. Additionally, a counteradaptation occurs, which involves the activation of the nuclear transcription factor CAMP response element binding protein. This activation results in increased expression of adenylyl cyclase within the locus ceruleus. In patients who are dependent on opioids, a drop in opioid concentrations leads to the loss of chronic inhibitory effects. Consequently, there is unchecked inward sodium ion flux, and the increased levels of adenylyl cyclase due to counteradaptation lead to calcium ion influx and cellular depolarization. The resultant increase in cellular excitability, particularly the uninhibited activity occurring at the locus ceruleus, manifests in the clinical symptoms associated with opioid withdrawal syndrome. Symptoms of opioid withdrawal include physical signs such as piloerection, yawning, and excessive tearing. Patients may also experience symptoms like nausea, vomiting, and diarrhea. While autonomic instability is minimal compared to the withdrawal from sedative hypnotic substances, mild tachycardia and elevated blood pressure may occur as a response to both physical and emotional symptoms. It is noteworthy that the mental status of individuals undergoing opioid withdrawal is almost always normal. Opioid withdrawal is characterized by a predictable constellation of physical signs and symptoms as well as psychological symptoms. Unlike withdrawal from sedative hypnotics such as alcohol or benzodiazepines, opioid withdrawal typically involves minimal autonomic instability and a normal mental status. Key clinical findings associated with opioid withdrawal include a range of physical signs and symptoms. Common physical signs consist of piloerection, yawning, and lacrimation. Patients often experience gastrointestinal disturbances, including nausea, vomiting, and diarrhea. Although some autonomic changes may occur, they are generally minimal. These changes may present as slight tachycardia and a minor elevation in blood pressure, typically in response to physical and emotional distress. The psychological symptoms of opioid withdrawal are significant, with an intense craving for opioids being a primary component. Patients frequently report feelings of being unwell during this period. Though opioid withdrawal is thoroughly unpleasant, it is unlikely to be life-threatening unless complications arise. Such complications may include aspiration pneumonitis or fluid and electrolyte abnormalities resulting from severe vomiting and diarrhea. The onset and duration of withdrawal symptoms vary depending on the specific opioid involved. In cases of heroin or morphine withdrawal, symptoms usually begin within 4 to 6 hours of a last dose, peak by 48 hours, and last for 3 to 5 days. In contrast, withdrawal from methadone has a delayed onset, beginning 1 to 2 days after the last dose, with a prolonged duration that may last 5 to 7 days or even up to 2 weeks. Iatrogenic withdrawal can occur when abrupt withdrawal is intentionally induced through the administration of opioid antagonists such as naloxone or naltrexone or partial agonists such as buprenorphine. This type of withdrawal is most commonly associated with the use of naloxone. It is typically short-lived due to naloxone's limited duration of action, which lasts approximately 40 to 60 minutes and usually requires no further intervention. However, withdrawal induced by longer-acting agents can be severe and prolonged, potentially leading to altered mental status. In newborns born to opioid-dependent mothers, withdrawal symptoms also vary in onset depending on the agent used. For example, heroin withdrawal symptoms typically begin within the first few days of life, while withdrawal from methadone might not become evident for 10 to 14 days. The symptoms experienced by neonates are similar to those of adults undergoing withdrawal, but can also include seizures, a high-pitched cry, skin mottling, and excoriation. These latter signs are more characteristic of opioid withdrawal than of withdrawal from alcohol in neonates. Diagnosing opioid withdrawal relies primarily on recognizing the characteristic clinical presentation in a patient with a history of chronic opioid use. This presentation occurs upon cessation or reduction of the drug. The withdrawal syndrome constitutes a predictable constellation of symptoms that result from lowered concentrations of the drug in the body. A critical aspect of the diagnosis involves excluding other potential medical conditions that can present with similar symptoms. Patients who are dependent on opioids often develop skills for self-treating their withdrawal symptoms. Therefore, when withdrawal is observed in a hospitalized patient, it may indicate an underlying illness that prevents them from using opioids. Such illnesses can include pancreatitis, pneumonia, head trauma, central nervous system infections, or gastrointestinal hemorrhage. It is essential to identify and address these conditions as they can contribute significantly to morbidity and mortality. The differential diagnosis for symptoms that might mimic opioid withdrawal includes conditions such as thyroid storm, hypoglycemia, encephalitis, serotonin toxicity, and neuroleptic malignant syndrome. Certain toxins can also cause symptoms resembling withdrawal. These include sympathomimetics, anticholinergics, caffeine, theophylline, lithium, aspirin carbamates, cathinones, and clenbuterol. Given that opioid withdrawal typically associates with a normal mental state, any alterations in mental status in a patient suspected of opioid withdrawal should prompt an investigation into these other potential causes. Regarding laboratory tests and imaging related to opioid withdrawal, there are no specific laboratory tests or imaging studies that can definitively diagnose opioid withdrawal. However, consistent with the approach to other withdrawal syndromes, especially severe or complicated presentations such as those seen in alcohol withdrawal, diagnostic testing plays a crucial role. These tests help evaluate the patient's overall status, identify comorbidities, and rule out other conditions on the differential diagnosis. Laboratory tests, while not specific to opioid withdrawal, may still be necessary. Routine laboratory analysis can include assessing serum chemistries such as glucose, magnesium, and calcium. These evaluations seek to identify underlying metabolic derangements that could arise from poor nutritional status or from vomiting and diarrhea, which are common during opioid withdrawal. A complete blood count can be used to check for conditions like bone marrow suppression or occult hemorrhage, especially in patients with substance use disorders. However, an elevated white blood cell count may also simply reflect a stress response. Depending on the patient's history and potential comorbidities, liver function tests and coagulation assays might also be relevant. Imaging studies are not usually necessary for uncomplicated opioid withdrawal, but become essential when there are concerns for other conditions or complications. For patients who present with altered consciousness or seizures, particularly relevant in cases of neonatal withdrawal or severe iatrogenic withdrawal, a computed tomography scan of the head is crucial to rule out intracranial issues like subdural hematomas, cerebral edema, or other structural lesions. A chest radiograph might help exclude pneumonia. If a central nervous system infection is suspected due to symptoms such as fever or altered mental status, a lumbar puncture may also be required. An abdominal computed tomography scan could be necessary to identify any other potential underlying disorders contributing to the patient's presentation, such as pancreatitis or cholecystitis. These diagnostic tests are primarily utilized to evaluate the patient's overall health, identify potential complications, and exclude other diagnoses rather than confirming opioid withdrawal itself. The management of opioid withdrawal focuses on alleviating unpleasant symptoms and supporting the patient throughout the withdrawal process. A fundamental principle in treating withdrawal syndromes is the readministration of the offending substance or a cross-tolerant agent to restore the lost inhibitory tone. One of the most direct approaches to managing opioid withdrawal is to reinstate the opioid. This is often achieved using medically acceptable opioids, such as methadone or morphine. Methadone is commonly utilized for both acute withdrawal and long-term maintenance. In acute situations, methadone can be administered parenterally, for example, 10 milligrams intramuscularly, especially if the patient is experiencing vomiting. Morphine is also a suitable alternative for acute treatment, typically dosed at 0.1 milligrams per kilogram intravenously, followed by appropriate titration. Oral opioids can also be used, with dosages adjusted according to their morphine equivalents. The objective is to relieve symptoms and then gradually taper the dosage. While benzodiazepines and barbiturates serve as primary treatments for withdrawal from GABAergic agents, such as alcohol and sedative hypnotics, they do not constitute the mainstay of treatment for opioid withdrawal. Benzodiazepines may alleviate some physiological symptoms, but they do not address the intense craving that is a central feature of opioid withdrawal. Clonidine, which is an alpha-2 adrenergic agonist, is effective in treating certain aspects of opioid withdrawal primarily related to autonomic symptoms. It accomplishes this by affecting the locus ceruleus and shared potassium efflux channels. Clonidine blocks acute withdrawal symptoms and helps suppress the abstinence syndrome. Although it can be beneficial as an adjunctive treatment, further trials are needed to establish best practices and appropriate dosing. In addition, antiemetics may be employed to manage nausea and vomiting. However, using clonidine or antiemetics alone may not relieve the intense craving, which could lead patients to discontinue treatment in search of opioids. In instances where withdrawal is induced by naloxone, supportive measures alone are typically sufficient because this type of withdrawal is short-lived and generally not life-threatening in an awake patient. For the ongoing management of opioid dependence, long-term therapy often includes methadone or buprenorphine maintenance programs. These programs combine pharmacotherapy, such as high-dose oral methadone or buccal buprenorphine, with counseling and support aimed at preventing continued illicit opioid use. Supportive care is essential, particularly when complications arise. This care involves addressing fluid and electrolyte abnormalities that may result from vomiting and diarrhea. Rehydration and substrate supplementation are fundamental principles in the management of withdrawal syndromes. In summary, opioid withdrawal is a distinct clinical syndrome characterized primarily by physical discomfort, gastrointestinal symptoms, and intense cravings, typically occurring without significant autonomic instability or altered mental status. Diagnosis is largely clinical and relies on recognizing symptoms and obtaining a detailed history, while laboratory tests and imaging studies are utilized to rule out other conditions or complications. Management focuses on employing medically acceptable opioids or cross-tolerant agents such as clonidine to alleviate withdrawal symptoms, complemented by supportive care and consideration for long-term maintenance therapy for dependence. In the context of alpha-2 adrenergic receptors, foreign substances like clonidine and dexmedetomidine act as agonists, stimulating these receptors. Clonidine, for instance, is an agonist that affects both the central and peripheral alpha-2 adrenergic receptors. Stimulation of central presynaptic alpha-2 adrenergic receptors typically inhibits sympathomimetic output, leading to effects such as a slower heart rate and lower blood pressure. Chronic use of these agents causes physiological adaptation within the alpha-2 adrenergic system. Therefore, withdrawal from chronic exposure to clonidine and related medications is associated with a distinct syndrome. The clinical presentation of alpha-2 adrenergic withdrawal is characterized by a significant surge in sympathetic activity, contrasting sharply with the effects of the agonist medication. Evidence and expert opinion indicate that within 24 hours of discontinuing chronic use of clonidine, there is an observable rise in norepinephrine concentrations. This increase can be attributed to heightened efferent sympathetic activity. The clinical manifestations arising from this sympathetic rebound include several cardiovascular findings. Hypertension and tachycardia are prominent features, reflecting the uninhibited sympathetic outflow that the alpha-2 agonist had previously suppressed. Additionally, patients may experience various physical symptoms such as diaphoresis, which is excessive sweating, and heightened anxiety levels. Neurological and psychological symptoms are also noteworthy. For instance, hallucinations have been reported in the context of clonidine withdrawal. Dexmedetomidine withdrawal, which is considered to be similar to clonidine withdrawal, also presents with agitation. It is important to highlight that although evidence and expert opinion define specific symptoms associated with clonidine and dexmedetomidine withdrawal, they do not provide a comparative analysis, such as a table analogous to those created for opioids, sedative hypnotics, alcohol, and cocaine. Nevertheless, the description of symptoms underscores significant autonomic hyperactivity, distinguishing it from the minimal autonomic instability typically observed in opioid withdrawal. The diagnosis of alpha-2 adrenergic withdrawal, similar to other withdrawal syndromes, is primarily clinical in nature. It is based on the recognition of a characteristic constellation of signs and symptoms in a patient who has a history of chronic exposure to an alpha-2 adrenergic agonist such as clonidine or dexmedetomidine upon the cessation or reduction of the dosage. This syndrome represents a predictable response to decreasing concentrations of xenobiotics. Withdrawal syndromes may mimic other medical conditions. Therefore, the diagnostic process must exclude other potential causes of similar symptoms. Evidence and expert opinions emphasize that many disorders can be mistaken for alcohol or sedative hypnotic withdrawal. These include thyroid storm, hypoglycemia, encephalitis, serotonin toxicity, and neuroleptic malignant syndrome. Furthermore, certain toxins such as sympathomimetics, anticholinergics, caffeine, theophylline, lithium, aspirin, carbamates, cathinones, and clenbuterol may also produce symptoms resembling withdrawal. While discussions of these differential diagnoses typically focus on alcohol and sedative hypnotic withdrawal, they remain pertinent for any patient presenting with agitation, autonomic instability such as tachycardia and hypertension, and potentially altered mental status that may include hallucinations or agitation as observed in alpha-2 adrenergic withdrawal. Consequently, distinguishing alpha-2 adrenergic withdrawal from these other critical conditions is a key aspect of the diagnostic process. Regarding primary laboratory tests and imaging in alpha-2 adrenergic receptor withdrawal, it is important to note that no specific laboratory tests or imaging studies definitively diagnose alpha-2 adrenergic withdrawal. Instead, the diagnosis is established clinically based on the patient's history and presentation. However, following general principles for evaluating patients presenting with withdrawal syndromes, particularly those exhibiting significant autonomic changes or potential complications, laboratory and imaging studies play a crucial role. These studies help assess the patient's overall status, identify comorbidities, and rule out conditions included in the differential diagnosis. In terms of laboratory tests, a routine analysis would typically involve evaluating serum chemistries such as glucose, magnesium, and calcium. These tests aim to identify any underlying metabolic derangements that can exacerbate symptoms. A complete blood count may also be performed to check for infection or other hematological issues. Depending on the patient's history and risk factors, liver function tests and coagulation assays could also be relevant. While serum levels of clonidine or dexmedetomidine may confirm exposure, expert opinions do not consider them necessary for diagnosing withdrawal. Imaging studies are not inherently required for diagnosing alpha-2 adrenergic withdrawal. Nonetheless, if concerning symptoms arise, such as altered mental status seizures, note that seizures are not specifically listed for clonidine withdrawal but can occur in other severe withdrawal syndromes like those associated with alcohol and gamma-hydroxybutyric acid, fever, or focal neurological signs. Imaging studies would be indicated to rule out other diagnoses. For instance, a computed tomography scan of the head is vital for excluding intracranial pathology such as subdural hematomas or cerebral edema. A chest radiograph can assist in identifying pneumonia. If a central nervous system infection is suspected, a lumbar puncture may be necessary. These studies are part of a broader workup to ensure that the patient's presentation results solely from withdrawal and is not complicated by or mimicked by another serious medical condition. In summary, while no specific laboratory tests or imaging studies confirm alpha-2 adrenergic withdrawal, a thorough evaluation utilizing these modalities remains essential to rule out other potentially life-threatening conditions that could present with similar symptoms such as hypertension, tachycardia, agitation, or hallucinations. The management of withdrawal syndromes generally involves re-administering the offending xenobiotic or a cross-tolerant agent to restore the previously present inhibitory tone. This fundamental principle aims to alleviate withdrawal symptoms. In the specific case of alpha-2 adrenergic withdrawal, evidence and expert opinion indicate that clonidine has been successfully used to treat dexmedetomidine withdrawal. This example demonstrates the application of the principle of using a cross-tolerant agent, or, in this case, the same class of agent acting on the same receptor system, to manage the withdrawal state. Clonidine, being an alpha-2 adrenergic agonist, works to inhibit the sympathetic overactivity that characterizes this withdrawal syndrome. It has also been shown to block acute opioid withdrawal symptoms and suppress the abstinence syndrome by acting through its effects on the locus coeruleus and shared potassium efflux channels. While evidence and expert opinion confirm the use of clonidine for managing dexmedetomidine withdrawal, they also note that clonidine has been studied as an adjunct in the management of other withdrawal syndromes, specifically alcohol withdrawal. In that context, clonidine was found to be effective at reducing blood pressure and heart rate, which are autonomic symptoms. However, it was deemed suboptimal as a sole therapy because it failed to address the underlying pathophysiological mechanism and neurological manifestations of alcohol withdrawal. Furthermore, the use of agents like clonidine in alcohol withdrawal raised concerns about masking the peripheral symptoms that are utilized in some severity assessment tools. This masking could potentially lead to undertreatment with the primary agent, which is benzodiazepines. Evidence and expert opinion emphasize that further formal trials are needed to define best practices and dosing recommendations for clonidine use in withdrawal syndromes more broadly. For the management of alpha-2 adrenergic withdrawal itself, such as from clonidine or dexmedetomidine, reinstating an alpha-2 agonist like clonidine to mitigate the sympathetic rebound appears consistent with the principles discussed. Supportive care is also a general principle in managing withdrawal syndromes. This care includes monitoring vital signs, ensuring adequate hydration, and addressing any complications that arise. The need for intubation is mentioned in cases of refractory severe withdrawal from gamma-hydroxybutyrate (GHB). This implies that aggressive supportive measures may be necessary in cases of severe, uncontrolled alpha-2 withdrawal. Although this is not explicitly stated in evidence and expert opinion for alpha-2 withdrawal, it is an important consideration. In summary, alpha-2 adrenergic withdrawal, occurring upon discontinuation of agents like clonidine or dexmedetomidine, presents with symptoms of sympathetic overactivity such as hypertension, tachycardia, anxiety, diaphoresis, agitation, and potentially hallucinations. Diagnosis is clinical, requiring a history of exposure and symptom recognition, along with evaluation to rule out other conditions. While no specific laboratory tests or imaging are diagnostic for this condition, these tools are essential for evaluating the patient's overall health and excluding other diagnoses. Management is guided by the principle of re-administering a cross-tolerant agent, with clonidine noted as effective for dexmedetomidine withdrawal. However, further research is needed to optimize its use in various withdrawal settings. Supportive care remains a critical component of overall management. Caffeine, along with other methylxanthines like theophylline, exerts its effects primarily by antagonizing adenosine, particularly at postsynaptic A1 receptors. Adenosine typically has inhibitory effects on the postsynaptic neuron by binding to A1 receptors. Chronic caffeine use leads to tolerance, involving neuroadaptations such as upregulation of A1 receptors, increased receptor affinity for adenosine, enhanced receptor coupling to G proteins, and increased G protein-stimulated adenylyl cyclase activity. These changes restore a state of physiological balance despite the presence of the antagonist. Upon the cessation of chronic caffeine use, the adaptive state persists, resulting in an exaggerated response to endogenous adenosine. The clinical findings that emerge are primarily due to the strong inhibitory effect allowed by the increased activity of adenosine and its receptor affinity. Caffeine withdrawal is recognized as one of the most common withdrawal syndromes and can be classified as a drug discontinuation syndrome that fulfills the criteria for withdrawal. The characteristic symptoms associated with caffeine withdrawal are highlighted by both evidence and expert opinion. Headaches are commonly reported, attributed to cerebral vasodilation, which may be a rebound phenomenon following the vasoconstrictive effects of caffeine. Fatigue is another prevalent symptom, aligning with the normal inhibitory function of adenosine that becomes unchecked during withdrawal. Additionally, hypersomnia or excessive sleepiness occurs as a reflection of unregulated motor inhibition mediated by adenosine. While the symptoms of caffeine withdrawal can be uncomfortable, both evidence and expert opinion indicate that this withdrawal is generally not life-threatening. Although this particular statement is framed in the context of selective serotonin reuptake inhibitor withdrawal, caffeine withdrawal falls under the broader category of drug discontinuation syndromes. It is essential to note that, unlike withdrawal from sedative hypnotics or severe alcohol withdrawal, caffeine withdrawal is typically not associated with significant autonomic instability or altered mental status. The diagnosis of caffeine withdrawal is primarily clinical. It relies on recognizing the characteristic symptom cluster, which includes headache, fatigue, and hypersomnia, in a patient with a history of chronic caffeine consumption who has ceased consumption or significantly reduced their intake. As a withdrawal syndrome, caffeine withdrawal fits the definition where symptoms begin when the concentration of the substance drops, and the syndrome abates when the substance is reinstated. This understanding aligns with the principles of withdrawal, where a pre-existing physiological adaptation requires the continuous presence of caffeine to prevent dysfunction. When clinicians evaluate a patient with symptoms suggestive of withdrawal, they should always consider other potential medical conditions or toxic exposures as part of the differential diagnosis. While caffeine withdrawal symptoms are generally distinct, caffeine itself is classified as a toxin that may mimic some symptoms seen in alcohol or sedative hypnotic withdrawal. However, the specific symptoms described for caffeine withdrawal, namely headache, fatigue, and hypersomnia, are generally opposite to the excitatory or hyperadrenergic symptoms observed in alcohol or sedative hypnotic withdrawal. These can include tachycardia, hypertension, tremor, agitation, and hyperthermia. In the context of adenosine receptor withdrawal, specifically caffeine withdrawal, there are no specific laboratory tests or imaging studies that are diagnostic for this condition. Based on the general approach to evaluating patients with withdrawal syndromes, diagnostic studies are primarily utilized to assess the patient's overall status, identify potential complications, and rule out other conditions that may present with overlapping symptoms. Routine laboratory analyses might include serum chemistries such as glucose, magnesium, and calcium, along with a complete blood count to evaluate for underlying metabolic derangements or other comorbidities that may be present in patients dealing with substance use issues. However, specific metabolic derangements are not typically noted for uncomplicated caffeine withdrawal. Imaging studies like computed tomography scans of the head or chest radiographs are usually indicated when there are concerns for more severe presentations, such as altered mental status or seizures. However, since caffeine withdrawal is typically characterized by a normal mental status and does not usually involve seizures, these investigations would not be standard for uncomplicated cases of caffeine withdrawal. Instead, they would be guided by the presence of atypical features or suspicion of other diagnoses. Therefore, primary laboratory tests and imaging studies are not considered essential for diagnosing or managing straightforward caffeine withdrawal. The management of withdrawal syndromes, including caffeine withdrawal, fundamentally involves addressing the underlying neurobiological imbalance caused by the removal of the substance that has been used chronically. The general principle is to re-administer the offending xenobiotic or a cross-tolerant agent. In the case of caffeine withdrawal, the syndrome typically diminishes when the xenobiotic is reinstated. This understanding ties into the pathophysiology that involves an exaggerated effect of adenosine. Therefore, the most direct and effective treatment for caffeine withdrawal is administering caffeine. This action restores the competitive antagonism at the adenosine receptors, counteracting the strong inhibitory tone and alleviating the symptoms experienced by the individual. Although specific evidence and expert opinions related to caffeine withdrawal management are not extensively detailed, providing supportive care is a general principle applicable to any withdrawal syndrome. Supportive care usually involves ensuring adequate rest and hydration, especially when symptoms such as headache are severe. Unlike withdrawal from substances like alcohol or sedative hypnotics, which require carefully titrated cross-tolerant medications such as benzodiazepines or barbiturates due to the risk of potentially life-threatening symptoms, caffeine withdrawal management tends to be much simpler. It is primarily centered on reintroducing caffeine to the individual. In summary, caffeine withdrawal manifests through symptoms such as headache, fatigue, and hypersomnia due to exaggerated effects of adenosine following the cessation of chronic use. The diagnosis of caffeine withdrawal is typically clinical. Laboratory tests and imaging studies are not generally necessary unless other diagnoses are suspected. Management involves the readministration of caffeine to alleviate the presenting symptoms. Nicotine, a significant xenobiotic affecting acetylcholine receptors, particularly the nicotinic type, is associated with a well-recognized withdrawal syndrome. Nicotinic receptors are a class of acetylcholine receptors found in various locations throughout the body, including autonomic ganglia, the adrenal medulla, the central nervous system, CNS, the spinal cord, the neuromuscular junction, and the carotid and aortic bodies. Unlike muscarinic receptors, which are coupled to G proteins, nicotinic receptors are fast-response cation channels. Chronic exposure to nicotinic agonists, such as nicotine in cigarettes, leads to neuroadaptations. These changes appear to be related to the selective upregulation of nicotinic acetylcholine receptors and the selective upregulation of the cyclic AMP pathway in the amygdala. These adaptive changes result in a state where the continuous presence of the xenobiotic is required to prevent dysfunction. When this chronic presence is removed or reduced, the adaptive changes persist, leading to a withdrawal syndrome. Nicotine withdrawal is noted as one of the most common withdrawal syndromes, following closely behind alcohol withdrawal. While evidence and expert opinion discuss the pathophysiology involving receptor upregulation and the CAMP pathway leading to behavioral distress, they do not provide a comprehensive list of all possible clinical manifestations for nicotine withdrawal other than highlighting behavioral distress. In the broader context of withdrawal syndromes, which represent a predictable constellation of symptoms when xenobiotic concentrations drop, it is understood that withdrawal symptoms begin when the xenobiotic concentrations drop and the syndrome abates when the xenobiotic is reinstated. While specific symptoms like headache, fatigue, or hypersomnia were described for caffeine withdrawal related to adenosine receptors, and symptoms like tachycardia, hypertension, and tremor for alcohol withdrawal related to GABA/NMDA receptors, evidence and expert opinion focus on behavioral distress as a manifestation related to the neurobiological changes associated with nicotine withdrawal. The diagnosis of nicotine withdrawal, like other withdrawal syndromes, is primarily clinical. It is based on the recognition of a characteristic constellation of symptoms in a patient with a history of chronic nicotine exposure, particularly when there is a cessation or significant reduction of use. Understanding withdrawal syndromes is fundamental to diagnosis. These syndromes begin when the concentration of the xenobiotic drops and abate when the xenobiotic is reinstated. Two defining characteristics of a withdrawal syndrome are the presence of pre-existing physiological adaptation to a xenobiotic and the combination of decreasing concentrations of that xenobiotic. When an individual requires the continuous presence of that xenobiotic to prevent dysfunction, withdrawal symptoms may arise. Another critical criterion for understanding the physiology of withdrawal and for guiding therapy is the ability to relieve withdrawal symptoms by taking the same or a closely related substance. Nicotine withdrawal aptly fits this definition, as symptoms begin when the concentrations of the xenobiotic drop, and the syndrome resolves upon reinstatement of the xenobiotic. Therefore, establishing a diagnosis involves obtaining a history of chronic nicotine use, confirming recent cessation or reduction in intake, and identifying the onset of symptoms such as behavioral distress that resolve upon nicotine exposure. Clinicians must always consider other potential medical or psychiatric conditions in the differential diagnosis. However, it is noteworthy that evidence and expert opinion do not list differential diagnoses for nicotine withdrawal in the same manner as they do for alcohol or sedative hypnotic withdrawal. Regarding primary laboratories and imaging in acetylcholine receptor withdrawal, there are no specific laboratory tests or imaging studies considered primary or diagnostic for uncomplicated nicotine withdrawal itself. When evaluating patients presenting with potential withdrawal syndromes, evidence and expert opinion discuss laboratory tests and imaging primarily for identifying underlying medical issues, comorbidities, or complications, especially in more severe syndromes such as alcohol withdrawal. For example, in the case of alcohol withdrawal, serum chemistries, a complete blood count, liver function tests, and coagulation assays may be performed. However, routine laboratory tests for predicting the severity of withdrawal are of limited value. Imaging studies such as a chest radiograph or computed tomography scan of the head are indicated in cases of altered consciousness or seizures, primarily to rule out other pathological issues such as pneumonia or intracranial lesions. It is important to note that nicotine withdrawal is characterized by symptoms like behavioral distress and is not typically associated with life-threatening autonomic instability or altered mental status, which may be seen in severe alcohol or sedative hypnotic withdrawal. As such, routine laboratory or imaging studies are not indicated as primary investigations for nicotine withdrawal. Any diagnostic studies would be guided by the clinical presentation, particularly if there are atypical or severe features that suggest other underlying conditions. This approach emphasizes the need for a careful clinical assessment in the management of nicotine withdrawal. The fundamental principle guiding the management of withdrawal syndromes is the readministration of the xenobiotic from which the patient is withdrawing, or, in some cases, the administration of a cross-tolerant xenobiotic. This approach is grounded in the understanding that withdrawal syndrome occurs because a pre-existing physiological adaptation necessitates the continuous presence of the xenobiotic to prevent dysfunction, and the syndrome diminishes when the xenobiotic is reinstated. The presence of the second criterion of withdrawal, that the same or a closely related substance is used to relieve or avoid symptoms, is critical to understanding therapy. For nicotine withdrawal, the management aligns with this general principle. While evidence and expert opinion do not explicitly dictate specific doses or forms of nicotine replacement therapy, the overarching treatment philosophy for withdrawal syndromes, as described, is to restore the presence of the substance or a cross-tolerant agent. Since nicotine is the offending xenobiotic causing the withdrawal, its reintroduction in some form would be the logical therapeutic approach to counteract the persistent adaptive changes such as receptor upregulation and altered CMP pathway activity, thereby alleviating behavioral distress and other withdrawal symptoms. Although supportive care is a general component of withdrawal management, especially in more severe cases, like ensuring hydration or addressing comorbidities in alcohol withdrawal, the primary therapeutic intervention for nicotine withdrawal, based on the principles outlined, is the restoration of nicotine's effect at the nicotinic acetylcholine receptors. This reinstatement of the xenobiotic's presence allows the body to gradually readjust from the adapted state. The drug discontinuation syndrome associated with therapeutic use of selective serotonin reuptake inhibitors is, in fact, a withdrawal syndrome. Symptoms typically begin when the concentrations of the drug in the body decrease, and they tend to resolve with either the reinstatement of the substance or a gradual tapering off. Common symptoms of this syndrome include headache, nausea, fatigue, dizziness, and feelings of dysphoria. Although this condition can be uncomfortable for individuals, it is not generally considered life-threatening. In clinical presentation, drug discontinuation syndrome, particularly in relation to selective serotonin reuptake inhibitors, is characterized by a predictable array of symptoms that emerge when the concentration of the drug decreases in the body. This syndrome is recognized as a form of withdrawal. The usual symptoms associated with the discontinuation of serotonin reuptake inhibitors include headache, nausea, fatigue, dizziness, and feelings of dysphoria. While these symptoms may cause discomfort, the condition is generally deemed not life-threatening. The diagnosis of serotonin selective reuptake inhibitor discontinuation syndrome aligns with the definition of withdrawal syndromes as outlined in both evidence and expert opinion. Key features of this condition include the onset of symptoms when the concentration of the drug decreases. Furthermore, there is an abatement or resolution of these symptoms when the drug is reinstated. The term drug discontinuation syndromes specifically describes the symptoms resulting from the cessation of therapeutically used medications such as serotonin reuptake inhibitors. This categorization asserts that serotonin selective reuptake inhibitor discontinuation syndrome is, in fact, a type of withdrawal syndrome. It meets the definition where the same substance or a closely related one is taken to relieve or avoid symptoms. This concept contrasts with post-intoxication syndromes such as the crack crash from cocaine. These post-intoxication syndromes do not meet the aforementioned criterion and typically resolve spontaneously without medical intervention. Therefore, The diagnosis of serotonin selective reuptake inhibitor discontinuation syndrome is primarily clinical. It is based on the temporal relationship between the reduction or cessation of the medication and the appearance of characteristic symptoms. Additionally, symptoms tend to resolve upon reintroduction of the medication or a slow tapering off. When it comes to primary laboratory tests and imaging studies, there are no specific assessments indicated for the routine diagnosis or evaluation of uncomplicated serotonin selective reuptake inhibitor discontinuation syndrome. Evidence and expert opinion suggest that this syndrome is uncomfortable but not life-threatening, indicating that extensive investigations are generally unnecessary in clear cases. In contrast, discussions surrounding other withdrawal syndromes, such as alcohol withdrawal, often contain details about necessary laboratory assessments. For instance, tests like serum chemistries, complete blood counts, and liver function tests are commonly required. Imaging studies, such as a computed tomography scan of the head or a chest radiograph, are primarily utilized to rule out coexisting medical conditions, complications from chronic use, or alternative diagnoses that may mimic withdrawal symptoms. Since serotonin selective reuptake inhibitor discontinuation syndrome is presented as a distinct and clinically less severe condition, these extensive investigations are not typically described as part of its primary evaluation. However, as with any clinical scenario, the necessity for laboratory tests or imaging would depend on the patient's specific presentation and the clinician's suspicion for other underlying issues. The management of SSRI discontinuation syndrome is primarily focused on symptom resolution as outlined in evidence and expert opinion. The syndrome rapidly resolves with the reinstatement of a xenobiotic belonging to the same class. This aligns with the general principle that the treatment of a withdrawal syndrome typically involves readministration of the xenobiotic from which the patient is withdrawing. Alternatively, the syndrome can resolve more slowly if the medication is discontinued using a more gradual taper. For withdrawal syndromes that meet the criterion of symptom relief upon reinstatement, which SSRI discontinuation syndrome is stated to meet, treatment involves reinstatement and gradual withdrawal of the xenobiotic. Given that the condition is described as uncomfortable but not life-threatening, the primary management strategies involve either reversing the withdrawal symptoms by restarting the medication or mitigating their severity through a slow and controlled reduction in dosage. Supportive care measures, such as those appropriate for managing discomfort and specific symptoms like nausea or headache, would also be a logical component of management, although not explicitly detailed in evidence and expert opinion for SSRIs specifically. This contrasts with conditions like alcohol withdrawal, which requires aggressive therapy with sedative hypnotics, often benzodiazepines, titrated to effect to control potentially life-threatening symptoms such as seizures, autonomic instability, and delirium tremens. This is a summary of the key points regarding withdrawal syndromes, a fundamental concept in medical toxicology and patient care. Understanding these points is essential for diagnosing and managing patients who have become physiologically dependent on various substances and experience symptoms upon cessation. A withdrawal syndrome is defined as a dysfunctional state occurring when an individual who has physiologically adapted to a xenobiotic experiences a decrease or removal of that substance. This condition requires both a pre-existing physiological adaptation to a xenobiotic and a decrease in its concentration. At the core of withdrawal is the significant reduction in tonic inhibitory neurotransmission. This reduction leads to a state of excitation within the central nervous system. Chronic exposure to substances causes adaptive changes that necessitate the substance's presence to maintain baseline function. When the substance is removed, these changes become maladaptive. Withdrawal is distinct from simple tolerance, which involves requiring more of the substance for the same effect, and addiction characterized by compulsive drug-seeking behavior. Withdrawal syndromes commonly involve substances that affect inhibitory pathways. Specifically, the evidence covers several key receptor systems and substances involved in withdrawal. These include GABA-A receptors that are affected by barbiturates, benzodiazepines, ethanol, and volatile solvents. GABA B receptors are implicated with baclofen and gamma-hydroxybutyrate. Opioid receptors relate to opioids, while alpha-2 adrenergic receptors are affected by clonidine and dexmedetomidine. Adenosine receptors, particularly affected by caffeine and serotonin reuptake inhibitors, which are described as a drug discontinuation syndrome, but are in fact a withdrawal syndrome, are also of interest. The diagnosis of withdrawal syndromes is primarily clinical based on the history of chronic use, cessation or reduction, and characteristic symptoms. It is vital to rule out other medical or toxicological conditions that may present similarly. While laboratory tests and imaging are not typically diagnostic of withdrawal itself, they are essential for ruling out differential diagnoses, assessing comorbidities, and identifying complications, especially in severe cases. The general management principle involves readministration of the offending xenobiotic or cross-tolerant agent to restore inhibitory tone and alleviate symptoms. Supportive care is also crucial in managing withdrawal syndromes. To summarize specific syndromes, starting with GABA A withdrawal, a decrease in GABA A activity coupled with upregulated NMDA activity leads to central nervous system excitation and autonomic stimulation. This can present clinically as a spectrum ranging from tremor and anxiety to agitation, hallucinations, seizures, delirium, tachycardia, hypertension, diaphoresis, and hyperthermia. The diagnosis is clinical, and tools such as the Clinical Institute Withdrawal Assessment for Alcohol, CIWA-AR, or the Richmond Agitation Sedation Scale, RASS, can guide management. Medical practitioners must rule out sympathomimetic or anticholinergic toxicity, thyroid storm, and infections. The first-line management for GABA A withdrawal is benzodiazepines, which are cross-tolerant. In refractory cases, barbiturates such as phenobarbital or propofol may be necessary. It is important to avoid using antipsychotics, beta blockers, or clonidine as monotherapy because these do not address the core issue. In GABA B withdrawal, the loss of chronic GABA B inhibition leads to neuronal hyperactivity. Baclofen interacts via calcium channels, and GHB acts on GABA B and GHB receptors. Clinically, patients may experience seizures, hallucinations, psychosis, dyskinesias, hypertension, and coma with baclofen. GHB withdrawal symptoms often resemble those of alcohol or benzodiazepine withdrawal, including tachycardia, hypertension, tremors, agitation, and hallucinations, although seizures may be less common. The symptoms can often be protracted. Diagnosis is also clinical based on the history and the timeline of symptom onset. Management typically includes reinstating baclofen, while benzodiazepines or GABA agonists should be used for seizure control. For GHB, management may be similar to alcohol or benzodiazepine withdrawal with high-dose benzodiazepines alongside supportive care. Opioid withdrawal involves a counteradaptation, leading to increased cellular excitability once the opioid is removed. Physical signs can include piloerection, yawning, and lacrimation, alongside gastrointestinal symptoms such as nausea, vomiting, and diarrhea, with intense craving being very common. There is typically minimal autonomic instability, and the mental status is usually normal. Opioid withdrawal is not typically life-threatening unless complications arise, and the onset of symptoms varies by the opioid's half-life, hours for heroin and days for methadone. Diagnosis is clinical, relying on the history of use and characteristic symptoms, while other causes should be ruled out, especially if there are signs of altered mental status. Management would typically involve the reinstitution of a medically acceptable opioid such as methadone or morphine. Clonidine may assist with managing autonomic symptoms, but should not be used as monotherapy. Supportive care is crucial for gastrointestinal losses, and benzodiazepines are not considered a primary treatment option. Alpha-2 adrenergic withdrawal occurs due to sympathetic rebound after the cessation of an alpha-2 agonist. This results in a rise in norepinephrine. Clinically, symptoms can include hypertension, tachycardia, diaphoresis, anxiety, agitation, and hallucinations, indicating significant autonomic hyperactivity. The diagnosis is based on clinical criteria, using the history of alpha-2 agonist use and the presence of characteristic sympathetic surge symptoms while ruling out other hyperadrenergic or agitated states. Management typically calls for the readministration of an alpha-2 agonist like clonidine, which blocks the sympathetic rebound effect, with supportive care being critical. Lastly, caffeine withdrawal involves antagonism of adenosine, resulting in a 1-receptor upregulation. Therefore, cessation leads to exaggerated adenosine effects. Clinically, this can present as headache due to cerebral vasodilation, extreme fatigue, and hypersomnia. While generally uncomfortable, caffeine withdrawal is typically not life-threatening, resulting in minimal autonomic instability or alterations in mental status. Diagnosis relies on a clinical history of chronic caffeine use and the presence of characteristic withdrawal symptoms. The management involves readministration of caffeine to alleviate these symptoms. Acetylcholine and nicotine play significant roles in behavioral distress. The pathophysiology involves a selective upregulation of nicotinic receptors and the cyclic adenosine monophosphate pathway in the amygdala, which contributes to feelings of behavioral distress. Clinically, individuals experience behavioral distress when their concentration drops, and these symptoms tend to abate with the reinstatement of nicotine. The diagnosis is primarily clinical and is based on the patient's history of nicotine use or cessation, as well as the correlation of symptom onset and resolution with re-exposure to nicotine. A common management strategy includes the readministration of nicotine, such as through nicotine replacement therapy. In the case of serotonin reuptake inhibitors, the pathophysiology is often described as a drug discontinuation syndrome, which meets the clinical definition of withdrawal. Patients may experience symptoms such as headache, nausea, fatigue, dizziness, and dysphoria. Although these symptoms can be uncomfortable, they are not life-threatening. Diagnosis for the syndrome is also clinical and involves observing the onset of symptoms in relation to a drop in concentration, with resolution occurring following reinstatement or tapering of the medication. Management typically involves reinstating the serotonin reuptake inhibitor or implementing a slow, gradual taper of the medication, as symptoms rapidly resolve with reinstatement. These points cover the essential elements of withdrawal syndromes, providing a comprehensive framework for understanding their underlying mechanisms, clinical manifestations, diagnosis, and management based on evidence and expert opinion.
This was an episode of the Nexus Clinical Podcast. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this content is at the user's risk. This is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay seeking medical advice for any medical condition they have, and they should consult their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.